Now, how do you treat these patients of Cushing syndrome? How do you basically go about and make a management plan when you know the definitive diagnosis and when you know the underlying pathologies? What can be the challenges that you face when you are treating these patients? Because there are certain precautions that you have to take when you basically manage these patients of Cushing syndrome. So this is a very comprehensive flow chart that basically give you an overview regarding the treatment guidelines of the Cushing syndrome. The ACTH-dependent hypercortisolism, if it is diagnosed in an individual, you would conduct a pituitary MRI and then basically go for the petrosal sinus ACTH sampling. So you know that you have an ACTH-dependent cortisolism that you're dealing in with. You would conduct tests to rule out what is the etiologenesis, what is the underlying pathology in this particular case. If after conducting the MRIs, you're sure of the fact that you're dealing with a pituitary adenoma and is basically an ACTH secreting pituitary adenoma, you would consider the chest abdominal imaging to rule out any ectopic ACTH producing tumors. For instance, we studied the bronchial carcinoid tumors, which can produce the ACTH, and you would be basically ruling that out in these particular cases. The transsphenoidal surgical resection is done in cases of ACTH secreting pituitary adenomas. So surgery is the option. It's the treatment of choice in cases of pituitary adenomas. A biochemical cure and persistent hypercortisolism is basically, it can result in these two fates. Even after surgeries, the patients have persistent hypercortisolism and sometimes they have biochemical cures as well. The glucocorticoid replacement is done if it is needed, and you follow up the patient. Serial biochemical and MRI evaluation is also done. Persistent hypercortisolism is seen in a lot of patients, and for them you can opt for a lot of oral drugs as well. We can opt for perisotide, glucocorticoid receptor antagonist, steroidogenic inhibitors, and pituitary irradiations are also done for these patients. Adrenalectomy is also performed for these individuals, and even after that, some patients show a recession and they even go, and again, when you would be conducting the test, they would show raised levels of cortisol. If there is a persistent hypercortisolism, a biochemical cure can be looked for. Sometimes, even after adrenalectomy, these patients can go into Nelson syndrome. Now, what is Nelson syndrome? Basically, when you remove the adrenals, there is a positive feedback and there is an increased secretion of the ACTH hormones, and that is again going to give rise to hyperpigmentation in these individuals. So Nelson syndrome is one of the phenomena that is seen with the treatment irradiations, and sometimes for these patients you look for the irradiation techniques to slow down the production of the ACRH. So this is how basically you manage these cases, either surgically, either you give or couple up the oral medications or perform irradiations for these particular patients. So over here in this particular lecture, we went through in detail and discussed the etiologenesis, the pathogenesis, the differentials, and what is the basic management guidelines that you would encompass when you have a definitive diagnosis of this Cushing syndrome. Again, it's very important that you be aware of the asymptomatic Cushing syndrome and the pseudo-Cushing syndrome that is sometimes present, and you look for these particular features. Not all people with a moon face, obesity, and the particular features of Cushing syndrome that we discussed over here are truly suffering from this particular syndrome. So you'd have to basically rule out the patients and then start off with a particular management guideline in these patients. So that is the end. Thank you for watching sqadia.com.